Imagine opening up the body's most highly secured, densely packed engine room. Like you have the heart and lungs, the main power generators, and they're surrounded by this completely impenetrable cage of bone.
Right, and if you get the wrong wire in that room, the whole ship basically loses power.
Exactly. So, welcome to the deep dive. Today, we are undertaking a really critical mission for you listening. We're taking a massive stack of source material, mainly the foundational insights from Key Questions in Thoracic Surgery by Morjani, Viola, and Walker, and distilling it down.
Yeah, into a high-yield, comprehensive guide to the human chest cavity, which is perfect if you are a medical student, a young professional stepping onto the surgical ward, or really just a self-taught learner who wants to master clinical anatomy.
Because we aren't just going to tell you, where things are. Okay, let's unpack this. Removing a part of a lung or mapping a tumor requires knowing exactly where the plumbing and wiring run.
Right, that engine room metaphor is perfectly fitting. Operating within the thorax, or even just accurately diagnosing conditions there, requires a level of precision that goes way beyond basic biology.
Because textbook anatomy is static, right?
Exactly. But anatomy on the operating table, or in the trauma bay, is living, breathing, and highly reactive. Our goal today is to bridge that gap. We really need to explore why these structures behave the way they do when disease or a surgeon's scalpel intervenes.
Okay, so let's look at the blueprint. Before we can even discuss opening up the chest, we have to define the walls of the engine room. And the most central, critical compartment of this entire cavity is, well, the mediastinum.
Yeah, the mediastinum.
For you listening, picture the human chest. The mediastinum is that vital real estate situated squarely between the two lungs.
And it has very rigid, unforgiving boundaries. I mean, if you visualize it,
Well,
laterally you are boxed in by the left and right pleural cavities holding the lungs.
right.
Anteriorly, you have the sternum acting as a frontal shield. Posteriorly, the vertebral column forms this solid pillar.
And it's capped on top and bottom, too.
Yep. Superiorly, it's capped by the thoracic inlet, and inferiorly, it rests right on the muscular floor of the diaphragm.
Yeah.
But clinically, surgeons don't just look at it as one big box.
No, they use Shield's three-compartment model, don't they?
Exactly. They rely heavily on that model to map out where, say, a tumor or an infection might be hiding.
Let's visualize that 3D map for a second. Shield divides the mediastinum front to back. So you have the prevascular compartment right behind the sternum, housing things like the thymus gland and fat.
Right.
Then the visceral compartment in the middle. That one contains the heavy hitters, the heart, the pericardium, the trachea, and the esophagus.
And finally, the paravertebral compartment in the back, which splits into bilateral sulci along the spine and houses the spinal nerves.
I got it.
And cutting horizontally across this entire map is something called the thoracic plane. This is a vital anatomical cross-section.
Wait, where exactly is that plane?
So if you draw a line from the manubriosternal junction, which is commonly known as the angle of Louis on the front of the chest, straight back to the inferior border of the T4 vertebra, you hit this incredibly busy vascular and airway intersection.
It's basically the grand central station of the chest.
Oh, absolutely.
I mean, on this exact plane, you find the inferior aspect of the aortic arch. You find the bifurcation of the main pulmonary artery splitting left and right.
Yeah, the ligamentum arteriosum is there too.
And crucially, you find where the azygos vein, the chest's major alternative venous drainage system, arches directly over the right main bronchus to dump its blood into the superior vena cava.
That is exactly why understanding this plane is non-negotiable. If trauma or a tumor disrupts the thoracic plane, it threatens multiple catastrophic failure points all at once.
Wow. And protecting all of this delicate plumbing is the rib cage, right? 12 pairs of ribs articulating with the spinal column in the back.
Let's break those down because they really aren't all built the same. You've got the first 7 pairs, the true ribs. They articulate directly with the sternum in the front via their own costal cartilages.
Okay. And the rest are false ribs.
Yeah, 8 through 12, 8, 9, and 10 sort of piggyback on the cartilage above them. And then 11 and 12 are just floating ribs with no anterior attachment.
But I want to focus on the clinical reality here. Because the most important part of a typical rib isn't actually the outer bone protecting against blunt force. It's the underside of the bone.
Oh, the costal groove, yes.
Yeah.
On the inferior inner aspect of every typical rib, there's a groove that houses the neurovascular bundle.
Right, the Van bundle.
Exactly. Vein, artery, nerve running from top to bottom within that groove.
And this is exactly why clinical procedure is dictated by anatomy. Like if you are in the ER and you have to place a chest drain to relieve a collapsed lung, You always advance your instrument over the top margin of the rib below your target space.
Never into the rib above it.
Right. If you go under, you run the risk of lacerating that intercostal artery, and suddenly a routine procedure turns into a massive hemorrhage.
And a perfect example of anatomy dictating surgical technique. And looking at the entire cage, the very top boundary is formed by the first rib, the manubrium of the sternum, and the T1 vertebra.
Wait, let me stop you there. Because anatomically, that top bony circle is called the thoracic inlet. But I want to push back on this terminology.
Okay, go for it.
If anatomists firmly call it the inlet, why do clinicians and surgeons constantly refer to compression of the neurovascular bundle in this exact same area as thoracic outlet syndrome? It seems like a massive contradiction.
This raises an important question, and it highlights a fascinating friction between the pure anatomy lab and the reality of the clinic.
How so?
Well,
Yeah.
anatomically, it is classified as an inlet because it is the physical opening where outside elements, air and food, enter the chest cavity from the neck.
Okay, that makes sense for anatomy.
But a clinician is looking at the flow of the body's resources. So to a clinician, it is an outlet because it is the exit point where the major vessels, like the subclavian artery and the brachial plexus nerves, actually leave the chest cavity to supply the arm.
Ah, I see. So when those exiting nerves and blood vessels get compressed on their way out, say, by an extra cervical rib or like a tight scaling muscle, clinicians call it thoracic outlet syndrome because the exit is blocked.
Exactly. Clinical communication has to bridge the gap with pure anatomy to describe the actual physiological consequence for the patient.
That structural logic makes total sense. So now that the walls and the exits of our engine room are defined, let's look closer at the vital tubes and wires running through the center.
Because when we talk about surgical complications, this central wiring is usually where things go wrong.
Yeah, and I want to start with the sympathetic chain.
Good place to start. The sympathetic chain is the wiring for the autonomic nervous system, responsible for the fight-or-flight response. You're dealing with 23 paired ganglia, running vertically 3 cervical, 12 thoracic, 4 lumbar, and 4 sacral.
And in the chest, they just lie beneath the parietal pleura, draping right over the neck of each rib. But do we actually care about all 23 of those in thoracic surgery? Or is there a specific troublemaker we have to watch out for?
There is absolutely a specific troublemaker, the stellate ganglion. It is formed by the fusion of the inferior cervical ganglion and the first thoracic ganglion, sitting right up near that thoracic inlet we just discussed.
And damage to this specific ganglion causes Horner syndrome.
Exactly.
Like if you were operating near the apex of the lung and you accidentally sever or damage that stellate ganglion, the patient wakes up with a very specific, permanent set of unilateral facial signs.
That's quite striking to see.
Yeah. They have aptosis, which is a drooping upper eyelid. They have miosis, a constricted pupil that won't dilate. And they have anadrosis, which is a complete lack of sweating on that side of the face. You've essentially cut the sympathetic wiring to half of their head.
Which is devastating for the patient. Beyond the wiring, though, we have to look at the major plumbing, specifically the esophagus.
Right, the food tube.
It's a muscular tube about 25 centimeters long, carrying food from the pharynx to the stomach. But to get from the chest into the abdomen, it has to pass through the muscular floor of the engine room, the diaphragm.
And the diaphragm isn't just a simple sheet. It's this dynamic muscle of respiration with 3 very specific, highly engineered openings at exact vertebral levels.
Let's map these out and explain why they are built the way they are.
Okay, at the level of the T8 vertebra, you have the caval hiatus. This is for the inferior vena cava.
And it passes through the central tendon of the diaphragm at T8. Why? Because the tendon doesn't contract like the muscle does. The body needs that massive vein to stay open to return blood to the heart, so it runs through the rigid tendon where breathing won't squeeze it shut.
Brilliant engineering. Then at T10, you have the esophageal hiatus, which allows the esophagus and the vagus nerves to pass through.
Right, and this one actually passes through the muscular part of the diaphragm, the right crest specifically.
So that when the diaphragm contracts, it pinches the esophagus, acting like a sphincter to prevent stomach acid from refluxing into the chest.
Exactly. And finally, at T12, you have the aortic hiatus. This opening allows the descending aorta, the azygos vein, and the thoracic duct to pass.
But crucially, the aorta doesn't actually pierce the diaphragm, does it?
No, it passes behind it, between the crura and the vertebral column. Because if the aorta went through the muscle, every time you took a deep breath, you'd compress your main arterial supply to the lower half of your body.
It's all about flow and protection. Speaking of flow, let's shift to the airways. because the branching of the lungs is where anatomical relationships directly dictate disease.
Well, the right and left lungs are not symmetrical. The right main bronchus is wider, shorter, and much more vertical than the left.
Which is why inhaled foreign objects almost always end up in the right lung.
Exactly. But as you move deeper into the right lung, the anatomy becomes even more perilous. Let's look at the right middle lobe bronchus, or the RML bronchus.
Oh.
It branches off the bronchus intermedius, but its physical path is incredibly crowded. It passes intimately under the right lower lobe pulmonary artery branch and then sits wedged right between the superior pulmonary vein and that arterial branch.
Here's where it gets really interesting. The best way I can picture this is to imagine a soft rubber garden hose that is wedged tightly between two hard, unyielding tree roots.
That's a great visual.
The hose is your airway, and the roots are those major vascular structures.
And wrapped all around that garden hose are lymphatic tissues. If we connect this to the bigger picture, it explains the mechanism behind middle lobe syndrome.
Oh, because that RML bronchus is wedged in there so tightly, it is uniquely vulnerable to extrinsic nodal compression.
Right. If those surrounding lymph nodes swell, maybe due to a respiratory infection, tuberculosis, or a malignancy, they expand outward and literally pinch off the right middle lobe bronchus.
So the soft hose is crushed against the unyielding roots. The lobe completely collapses, mucus builds up behind the blockage, and the patient suffers from severe recurrent pneumonias.
Which brings us perfectly to those lymph nodes themselves. If you are a surgeon operating for non-small cell lung cancer, you don't just take out the tumor.
No, you have to map and remove the lymphatic drainage to see if the cancer has spread.
And the International Association for the Study of Lung Cancer, the IASLC, has established a very specific numbering system for this.
Yeah, they assign single-digit numbers for mediastinal nodal stations, the ones closer to the center of the chest, and a double-digit numbers for pulmonary stations, the nodes out deeper in the lung lobes themselves.
Like the Hiller nodes right at the root of the lung, which are station 10.
Right, and because lymphatic drainage in the human chest can be highly variable, the standard of care is emphatic. Accurate staging for non-small cell lung cancer absolutely requires the systematic dissection of all the ipsilateral mediastinal lymph nodes.
You can't just look at a scan and guess. You have to physically harvest the nodes from those single-digit stations on the side of the tumor and send them to pathology.
This transition from anatomical structure to physiological function is where things get really fascinating. Once we know the physical layout, we have to evaluate the mechanics.
We have to understand the physics of breathing. And crucially, we must predict how well the patient will function if we decide to surgically remove a piece of that anatomy.
So let's talk about the underlying physics of ventilation. It all comes down to transpulmonary pressure.
Right.
This is defined as the difference between the alveolar pressure, which is the pressure inside the tiny air sacs of the lungs, and the intrapleural pressure, which is the pressure in the sealed cavity surrounding the lungs.
During a normal inspiration, your diaphragm drops and your chest wall expands outward. This generates a negative vacuum in the intrapleural space, dropping the pressure to about -4 millimeters of mercury.
So this negative pressure essentially pulls the lungs outward. It makes the transpulmonary pressure positive, expanding the alveoli and physically sucking air down the trachea.
Exactly. But the lungs themselves are highly elastic. They constantly want to shrink down and collapse like a stretched rubber band.
So the only thing keeping them inflated is that negative vacuum pulling them against the chest wall.
Right. So if that transpulmonary pressure ever hits zero, meaning the pressure inside the pleura equalizes with the outside air, that inherent elastic recoil takes over, the lung completely collapses.
Which is the exact mechanism of a pneumothorax. Air enters the intrapleural space through a puncture in the chest wall or a ruptured bleb on the lung. The vacuum is lost, the pressure hits zero, and the lung just folds up.
Okay, so that explains the mechanical movement of air. Now let's explore gas exchange.
We measure this using the DLCO, or the diffusing capacity of the lungs for carbon monoxide. Usually when I think of a patient with lung disease like emphysema, we see their DLCO drop because the alveoli are destroyed and gas can't cross into the blood.
But there are several surprising conditions that actually cause an increased DLCO.
Yeah, an increased DLCO means more gas is transferring across the membrane into the bloodstream than normal.
This happens primarily in conditions associated with increased pulmonary blood flow or an increased volume of red blood cells. Think about left to right intracardiac shunts, where extra blood is being pumped through the lungs.
Or polycythemia, where a patient has a massive overproduction of red blood cells.
Exactly. If you have more red blood cells passing by the alveoli, you have more hemoglobin available to snatch up that carbon monoxide gas, artificially inflating the diffusion capacity.
But why does obesity or asthma increase DLCO? That seems counterintuitive.
It comes down to blood flow redistribution. In severe obesity, the heavy tissue compresses the chest wall. This forces a shift of blood volume upward into the apices, the upper zones of the lungs.
And those are normally less perfused when you were sitting or standing, right?
Right. By forcing more blood flow through these upper zones, you increase the overall surface area of blood interacting with the gas. Asthma does something similar during early stages due to increased negative intrathoracic pressures pulling more blood into the pulmonary circulation.
Wow, this physiological nuance is critical when evaluating a patient preoperatively. Like, if a patient has lung cancer and needs a lobe removed, the surgeon must calculate their predicted postoperative function, commonly called their PAPO.
To do this math, you first have to know that the human lungs are divided into exactly 19 bronchopulmonary segments.
10 on the right, 9 on the left.
Yep. The right lung has 3 in the upper lobe, 2 in the middle, and 5 in the lower. The left lung is slightly smaller because of the heart, so it has 5 in the upper lobe, which includes the 2 segments of the lingula, and 4 in the lower lobe.
Okay, so let's simplify the math for the listener. Think of the lungs as a pizza cut into exactly 19 slices.
I love this analogy.
Right. You take a patient's preoperative FEV1, their forced expiratory volume in 1 second, which is basically how much air they can blast out. Let's say it's 2 liters. If we are removing a lobe that contains 3 segments, we are taking away 3 slices of the pizza. To find out what their breathing capacity will be after surgery, we multiply their starting 2 liters by the 16 remaining slices and divide that by the 19 total slices they started with.
That is the exact formula. You are mathematically determining if the remaining slices of the lung are enough to sustain the patient's life without leaving them ventilator dependent.
So we are essentially treating the lungs like a 19-slice pizza and doing basic fractions to decide if a patient will survive the surgery.
Essentially, yes. But there is a massive life or death caveat to this formula. Basic fractions only get you so far.
Right.
The clinical guidelines state that if your calculated predicted postoperative FEV1, or your PPO-DLCO, drops below 40% of a normal healthy baseline, the math is no longer sufficient to clear them for surgery.
Because at that point, the physiological margins are just too razor thin to risk it based on a simple fraction.
Precisely. If they hit that sub 40% threshold, you must pivot away from basic spirometry and move to a cardiopulmonary exercise test, or CPEX.
This isn't just breathing into a tube, is it?
No, it's putting the patient on a stationary bike or treadmill and measuring their VO2 max, their maximum rate of oxygen consumption.
What does VO2 max actually tell the surgeon functionally?
It tests the true integrated response of the entire system. It tells you how well the heart pumps, how well the lungs exchange gas under stress, and how well the muscles extract that oxygen.
And if their VO2 max is dangerously low during this stress test?
It proves their body cannot handle the metabolic demand of major surgery and the subsequent loss of a lung lobe. The whole ship will lose power, no matter what the 19-slice fraction initially suggested.
It's incredible how thoracic surgery requires this blend of spatial anatomy, basic arithmetic, and advanced physiological stress testing. But you can't just do all this math in the dark.
No, you definitely cannot.
Before any surgeon makes a cut, they need an exact visual map of the pathology. This brings us to imaging and radiology.
The standard frontline diagnostic tool is always the chest radiograph, the CXR. But anyone reading an X-ray must be vigilant about specific review areas where deadly pathology notoriously hides.
Like the apices at the very top.
Yes, you must deliberately train your eyes to check the lung apices, the HeLa in the center, the retrocardiac area completely hidden behind the shadow of the heart, and the areas below the dome of the diaphragm.
If a patient has a tension pneumothorax where air is trapped in the chest cavity and building pressure with every breath, an upright X-ray is going to show massive, unmistakable signs.
Oh, absolutely.
You'll see complete ipsilateral lung collapse. The intercostal spaces between the ribs will be widened from the pressure. The hemidiaphragm will be flattened or pushed downward, and the trachea and mediastinum will be forcefully shifted away from the side of the collapsed lung.
But here is the critical diagnostic hurdle. Those classic signs rely on an upright film where air naturally rises to the top of the chest.
Right, because of gravity.
Exactly. The reality in critical care is that we often have to rely on the supine chest radiograph, taken while the patient is lying flat on their back. When a patient is supine, The free air doesn't rise to the apices. It rises to the anterior chest wall and collects at the lung bases.
It doesn't look like a classic pneumothorax at all.
Not at all.
Instead of a collapsed lung at the top, you see increased lucency or unusual darkness in the hypochondrial region. You see an abnormally sharp heart border. And most famously, you see the deep sulcus sign, where the costophrenic angle at the bottom corner of the lung looks unusually deep, dark, and extended.
Which is incredibly subtle compared to an upright film.
But let me pause and ask the obvious question. If supine x-rays are notoriously terrible at showing a pneumothorax because the air goes to the wrong place, why do we even bother using them? Why not just sit the patient up for 5 minutes to get a clear picture?
What's fascinating here is that it comes down to the brutal constraints of the intensive care unit. Think about a patient suffering from acute respiratory distress syndrome, or ARDS. Radiologically, ARDS presents as widespread, bilateral, multifocal opacities that quickly progress to completely confluent consolidation. The lungs are stiff and filled with inflammatory fluid.
Right.
These patients are deeply sedated, paralyzed, intubated on complex ventilators, and heavily reliant on continuous infusions of blood pressure medications just to survive.
So they're far too hemodynamically unstable to be moved.
Exactly. Sitting them up could cause an immediate, fatal drop in blood pressure or dislodge a life-saving airway. Clinicians are forced to hunt for subtle secondary clues, like the deep sulcus sign, because a portable supine X-ray slid under the bed is the only imaging physically possible without killing the patient.
The patient's condition dictates the tool, but when a patient is stable enough for advanced imaging, the gold standard for mapping the engine room is the CT scan.
Yes.
And there's a lot of physics involved here, specifically the concept of pitch in a spiral CT.
Right. If the pitch is less than 1, the X-ray tube spirals very tightly around the patient, causing the tissue sampling to overlap. This gives you incredibly high-resolution, detailed images.
But if the pitch is greater than 1, the spirals are stretched wide, making the scan much faster, but you sacrifice some of that minute detail.
And clinicians constantly have to balance that desire for high detail against the radiation exposure, utilizing the ALAR principle, as low as reasonably acceptable.
You use the lowest possible radiation dose required to produce a definitively diagnostic image.
Exactly. And when utilized correctly, CT is unparalleled for identifying complex complications. Take pleural empyema, for example, which is a collection of thick pus in the pleural space.
A standard X-ray just shows a hazy white fluid collection there.
Right, but a CT scan with contrast will show smooth pleural enhancement and the classic split pleuris sign, revealing septations and pockets inside the pus that tell a surgeon exactly where they need to place their drainage tubes.
Beyond CT, we also utilize MRI and PET scans. For MRI, you are dealing with a massive magnetic field, which brings absolute contraindications.
You cannot place a patient in an MRI machine if they rely on a pacemaker-dependent rhythm.
Or if they have implantable cardioverter defibrillators, certain older cerebral aneurysm clips, or any metallic foreign bodies in their eye. The magnet will either rip the metal out or destroy the electronics, causing catastrophic harm.
And finally, PET scans. These use a radioactive glucose tracer to hunt down highly metabolic tissue, which is incredibly greedy for sugar.
Like cancer cells.
Yes, cancer cells are highly metabolic. We use PET-CT heavily for staging lung carcinoma. It can flag mediastinal lymph nodes that are less than 2 centimeters in size.
Nodes that might look totally normal on a regular CT, but are glowing hot on a P scan because they are packed with microscopic cancer cells.
Exactly. It is also the go-to tool for characterizing any solitary pulmonary nodule that is 10 millimeters or greater in size, especially if its location makes a physical needle biopsy too technically dangerous.
Wow, we have covered a massive amount of ground today. We started by defining the rigid boundaries and vascular intersections of the mediastinum.
We explored the exact functional reasons behind the diaphragm's hiatuses, the anatomical vulnerabilities of the right middle lobe bronchus,
The physical mechanics of transpulmonary pressure, and finally, the radiological physics of finding a hidden pneumothorax. So what does this all mean?
Well, if I can offer a final thought for you to ponder as we wrap up, we live in an era of unbelievable medical technology. A PET scan can flag a microscopic metabolic anomaly that is completely invisible to the naked eye. We have advanced algorithms and CPEX testing to predict precisely how a patient's cardiovascular system will handle the loss of a lung lobe.
Yeah, the tech is incredible.
But as these foundational texts continually remind us, the ultimate success of thoracic surgery still relies heavily on a surgeon's intimate, hands-on understanding of centuries-old anatomical relationships.
Right.
It relies on knowing exactly where the sympathetic chain hides beneath the pleura, why the esophageal vein arches where it does, or why a supine X-ray might be lying to you. It reminds us that technology enhances but never fully replaces a clinician's foundational mastery of the human body.
Absolutely. So, before we go, let's put you in the surgeon's shoes and apply this foundational mastery. To reinforce your learning today, grab a piece of paper, try to draw the 19 bronchopulmonary segments of the lung, remember, 10 on the right, 9 on the left.
That's a great exercise.
Then imagine a patient is sitting across from you in the clinic. They have a preoperative FEV1 of exactly 2.0 liters. You review their imaging, and you realize you have to take out their entire right upper lobe.
Which contains 3 segments.
Right. So remembering our anatomy, that lobe contains 3 of their 19 total bronchopulmonary segments. Can you do the basic math in your head right now to figure out what they will be left with?
It's their starting 2.0 liters, multiplied by the 16 segments they will have left, divided by the 19 total segments.
And remember, if that resulting number drops below 40% of normal, you can't operate based on fractions alone. You have to escalate to a stress test. The stakes in the engine room are truly that high.
They really are.
So the next time you look at a chest radiograph, don't just see a picture, see the plumbing, see the wiring, and see the engine room. Thank you for joining us on this deep dive. See you next time.